Okay. All right, let's get this show on the road. Hey, good morning, everybody. I'm Terri Conneran with KRAS Kickers, and I am delighted to see everybody this morning. And it is a beautiful day, as you already heard, and now it's more beautiful because I get to hang out with y'all. So thank you for being here. It is just an absolute treat this morning. And before I introduce to you the speaker, let me just kind of go through a couple of fun, social amenities if we could. Please keep your camera, or you can keep your camera on if you like. If your camera is on, we're assuming that that's okay for us to share your video. If you are living incognito, witness protection program, or you just don't want to show your face, that's okay. Go ahead and turn off your camera, please. And at the same time, please do stay muted. If you have questions, we'll be picking them up in the chat. I'm going to be trying to kind of paste those through the presentation as it seems appropriate. But if we miss any, I'll be happy to pull them back up at the very end. Let's see what else. This is important. Okay, now remember, we're talking about a drug that has an FDA approval, and as an FDA approved drug, part of the rules are that if, as a drug company, if they're aware of any adverse events and you share that you have an adverse event, it is obligation, it is the law that we need to follow up with you. So if you put something out there, don't put it out there if you don't want us to know about it. But if it is out there, we will have to follow up with you. So not a big deal. You're more than welcome to do it and more than welcome to share it, but just want you to know up front. We're delighted to have today with us Amgen, the company that has sotorasib, also known as Lumicras in the UK. And let me just tell you who, we have a couple of people with us here. The folks from Amgen, would you like to introduce yourself first before I introduce our amazing speaker?
Hi, everybody. Good morning. It's a privilege to be here with all of you today. My name is Michelle Carrillo. My team and I, we oversee Amgen's relationships with patient advocacy groups. And it has been truly an honor to be part of this journey with Terri over the last 2 years, watching this inspiring community come together. So thank you for having us today, Terri. I'm going to turn it over to my colleague, Tara.
Hi, I'm Tara Barbanel from Amgen, and I work in regulatory affairs. And regulatory is the liaison between Amgen and the FDA. We work to get drugs approved and available to patients. Super excited to be here today. So good morning, everyone.
Good morning. Well, thank you. Okay, now I'm going to introduce our amazing speaker. I-Fen Chang, and hopefully I'm not butchering your name, is the Vice President of Medical at Amgen. And she's going to chat with us this morning and share the information on Lumicras and sotorasib. And we are delighted to have you this morning with us. Thank you so much for joining us.
Thank you so much, Terri. And, on behalf of Amgen and my colleagues, I first of all wanted to extend my gratitude for this invitation, and also extend my gratitude for everybody for joining us for the next hour or so. We have a couple of goals and objectives that we're hoping to accomplish. First of all, we're going to start off at a very high level and really talk a little bit about the importance of molecular testing. As we know, this is the first step that is necessary to understand the specific type of lung cancer that a patient may have. But more importantly, it helps us understand whether or not a specific patient may be eligible for more of a personalized medicine or targeted therapy. Then we're going to switch gears a little bit, and I will talk about a very exciting new option that is now available for patients with a specific type of KRAS mutation known as KRAS G12C. We'll go through the efficacy data that led the FDA to grant an accelerated approval, and I'll talk a little bit about what an accelerated approval is. We'll talk a little bit about safety profiles and also medications, so things to avoid while taking Lumicras. And then I'm going to wrap up today's session with a little bit of information in terms of resources that are available that we have put in place through Amgen for both patients as well as physicians. We want to keep this conversational, so please feel free to submit your questions through chat, and Terri, feel free to interrupt me as we go through. and if something is not clear or if there's any question that's coming in. So let me pull up the presentation. But before we get started, I also want to, let me know if you're able to see.
Yep, we can see it.
Okay, perfect. So before we get started, I just want to remind the audience that this is an informational session. We are not here to provide medical advices around your specific care or treatment options, nor is this session meant to replace consultation with your physicians. As Terri had mentioned, any specific adverse events that you may be experiencing, particularly if you're being treated with Lumakras, we have an obligation as a company to report this back to the FDA. And the whole purpose of this is making sure that we collect all the safety information and that we are capturing this in totality now that the drug is FDA approved. Okay. So let's start, but before we go into the molecular testing, I just want to take a step back and really talk a little bit about the significance of the scientific advancements and the challenges that we have faced when it comes to targeting KRAS. So for more than 40 years now, we have known that KRAS is the most common protein that drives cancer growth. This is across a number of cancers, not only lung cancer, but also GI cancers, and in some cases, blood cancers. The reason why it's been so challenging to develop drugs against KRAS is because you can think of a KRAS protein almost like a tennis ball. It's got a very smooth surface, and because of this smooth surface, it's been very challenging for us as pharmaceutical companies to find a pocket, or what we call a groove, to develop drugs that could bind to it. As a matter of fact, it's been so challenging that the KRAS, or inhibiting KRAS, has historically been coined as drugging the undruggable. So about 10 years ago, some scientists at the University of San Francisco were able to find a pocket or a groove, particularly for patients with the KRAS G12C mutation. So with identification of this particular pocket, this led our scientists here at Amgen to start developing drugs against KRAS G12C. I think, in the interest of time, why don't we go to slide 4? So if you could advance 2 more.
Okay.
Then I can address a little bit about molecular testing and more specifically your
We
question.
pause on that one slide real quick. I would like to point out to everybody in this group here, the KRAS G12C, it looks like here, is about just the G12C is equal to about the number of people that have patients that have the EGFR. Okay, sorry, go ahead.
No worries, no worries. So as I was mentioning, the molecular testing is critically important for patients at the time of diagnosis because it's the first step to really understand the type of lung cancer that a patient may have. But more importantly, it really helps understand the specific mutations or what we call an actionable mutations, meaning that there is a personalized or targeted therapy from which the patient may be able to benefit. In many ways, lung cancer has become the poster child for personalized medicine. Over the last decade, we went from having 1 or 2 mutations or biomarkers for personalized medicine to today having more than 8 actionable mutations, which means that there's different subtypes of mutations as listed on this particular slide, where we now have an FDA-approved regimen is available. How does this translate to number of patients that could benefit? It's about 40% of non-squamous, non-small cell lung cancers today have an actionable mutations. More specifically, talking about KRAS, KRAS has multiple subtypes of mutations. The KRAS G12C is just one of those mutations. There's KRAS G12D, there's KRAS G12V, but KRAS G12C is the most common mutations that we have seen in lung cancer. As Terri had mentioned, it counts in the Western hemisphere for about 13 to 15% of the mutations that we see. It's about equivalent to the EGFR mutation. So based on the fact that there's now a broad range of actionable mutations, the NCCN guidelines nowadays encourages that when patients are eligible, they should be tested for actionable mutations. And you can see on the bottom of the slides which mutations are actionable. Includes KRAS, EGFR, ALK, ROS, BRAF, NTRK, MET, and RET. Okay, so the only way to know whether or not a patient has these mutations, it is necessary to do a molecular or a biomarker testing. So if we could go to the next slide, I want to dig a little bit deeper in terms of what are we seeing nowadays in terms of testing rates in the United States more specifically, but more importantly, what types of testings are available for patients and what is the ideal setting for those patients at diagnosis to get the most broad information about their subtypes of cancer. So on the left-hand side of this slide, you can see that despite the fact that I mentioned that we now have 8 actionable mutations, what we have noticed is that testing rates in the United States is still suboptimal. About 50% of patients are still not getting tested. And this has been a bit of a challenge in terms of really being able to identify the personalized approach for patients' care. The second thing to also highlight is that when we talk about testing, there's different ways of testing. There's what they would call single gene testing, where we test for one mutation at a time, or there is an approach called broad molecular testing, or what we can also hear physicians refer to comprehensive biomarker testing. The broad molecular testing is the preferred method of diagnosis because of a number of factors. It uses a single set of tissues and you're able to test for multiple mutations simultaneously. So it is cost effective and it also helps conserve tissues because you're able to use the minimal amount of tissues to give you the most information that you need. And it also preserves time because you're able to get your comprehensive results all at once rather than testing one gene at a time. So if we can go to the next slide, I want to talk a little bit more specifically about KRAS G12C. The ideal time for testing for patients with KRAS G12C, and this is also true for the other mutations, is really at diagnosis. When your physician goes in to get a sample to understand what subtypes of lung cancer you have, that is the ideal time to also do a broad panel testing to also understand whether or not a specific patient has a particular mutation that can benefit from targeted therapy. We also realize that that may not always be possible because, as we're starting to evolve and understand more about actionable mutations and more options become available, there are patients that got diagnosed many, many years ago for which at that time, for example, a KRAS G12C inhibitor may not have been available. So in the case where the patients may not have the results available, they're all alternative options to get tested as well. So options include physicians may want to go in and do another biopsy and get some fresh tissues to test. If that is not feasible, then we can also use what we call archival tissue or old tissues that were available or may have been left over from the time of diagnosis to retest and see if the patient has a KRAS G12C. In the case where getting tissue is not feasible for a patient, liquid biopsy is also an option where your physician may want to get a blood sample and test whether or not you have the specific KRAS mutation available through the blood samples. So if we could go to the next slide, I want to wrap this up real quickly and open it up to any questions that may be coming through the audience around testing. So in a summary, there are multiple types of biomarkers now that helps guide treatment in lung cancer. More specifically, there are 8 actionable mutations for which there are FDA-approved indications. The only way to understand whether or not you have a specific mutation is to conduct biomarker testing. KRAS G12C is one of the multiple biomarkers that we call actionable. As I mentioned, there are multiple types of KRAS mutation. KRAS G12C is a specific type of mutation that happens due to a single amino acid change. When we look at testing for KRAS G12C, the only way to understand whether or not you may be eligible for Lumakras or sotorasib, which is what we're going to talk about next, is to be able to understand whether or not you have this mutation through your biomarker testing. Okay, let me pause here for a second, Terry, see if you or the audience have any questions.
So like on old tissue, the first thing jumps to my mind is there like a time frame that they can look back at old tissue?
Yeah, it's a great question. So there is a time frame, and typically that time frame really is tied back to the assay and how much information we have collected, right? How much retrospective information that we have collected. For most of the tests that have been done through IHC is the type of testing that usually uses archival tissue. It's good for about a year or so. And the reason why the age of the tissue is very important is as time goes on, the protein starts to break down. So as the protein starts to break down, it becomes less sensitive to detecting that specific mutation. Okay.
So fresh tissue is best?
Fresh tissue is the best way to go. But realizing that getting a fresh tissue and getting a fresh biopsy in lung cancer patients may not always be feasible, right? The ideal situation is using fresh tissue. If that is not an option, we can go back and look at archival tissue. If that is still not an option, then liquid biopsy is also an alternative option for patients.
I have a quick question because I have to leave, unfortunately, for a medical conflict. I'm just curious, since you mentioned it before about the older variants. I happen to be G13C rather than G12. And I'm wondering, I haven't seen much research on the other variants. And I'm wondering how much research on the other variants is going on.
Yeah, Steve, great question. So Lumakras is very, very specific for the KRAS G12C. Now, your question is whether or not there is progress or research going on for the other variants such as G12V, G12D, and also some of the other mutations in other codons of the KRAS protein. Absolutely. There are efforts ongoing right now, for example, in G12D, there's programs that are entering the clinic very soon. I know that our scientists here at Amgen are working relentlessly to try to figure out, different proteins or different molecules that we can bring into the clinic to be able to target these other mutations.
Thank you very much. I'm sorry I can't stay for the rest of your excellent presentation so far, but thank you.
You're welcome. Thank you.
Take care. Good to see you all.
Wait a minute, hang on real quick here. Let me see if there's anything else popping up. So, all right. So as far as, let's see, so Jesse asked the question, can you address the issue of whether a patient should receive chemo prior to comprehensive biomarker results coming in?
Yeah, so very, very good question. We unfortunately cannot talk specifically about your specific options for you, but normally the ideal situation is that at the time of diagnosis, before the patient receives any therapy, the molecular or comprehensive molecular testing should be performed. The molecular testing will help identify the best option for that particular patient, right? It may be chemotherapy, it may be immunotherapy, it may be a combination of those, or it may be a targeted therapy. And the only way how we can really understand what the options are for patients is really understand if the patient has a specific mutation or does not have a specific mutation.
Okay, and are we going to just be staying in the lung space here? Because I see a question on, what was it, cholangiocarcinoma?
Yeah, so just a reminder, the approval for Lumakras is specific for lung cancer. We'll go into that in a little bit more detail. The phase 1 studies that we conducted for Lumakras included a broad range of solid tumors, included pancreatic cancer, GI cancer, a bunch of other malignancies. At this point, we have very limited data. You have to keep in mind also that when you go into these rare mutations, the prevalence of these mutations become very, very, very small, right? So for example, in pancreatic cancer and colorectal cancer, we're talking about less than 3% of the patients having these mutations. So in the registrational study, as well as in our phase 1 study, the majority of the patients that were involved were lung cancer or colorectal cancers. Okay.
Yeah.
All right, should we switch gears a little bit and talk about Lumakras? So if we could advance. So we're very excited to be able to bring Lumakras to the market, and this was done in record times. The first patient was dosed on the sotorasib phase 1 study back in 2019, and we received FDA approval in May of 2021. This, we're excited that we're the first and the only approved KRAS G12C, and this approval was done in an accelerated fashion. Accelerated approval are granted by the FDA for certain drugs that meet certain criteria. For example, a drug has to meet the transformational efficacy and a safety profile that is acceptable from the FDA standpoint. It has to serve a population where there's high unmet need. And in parallel to that, the FDA also wants us to do a confirmatory study in parallel to get a full approval. And that confirmatory study for Lumakras has been completed. We're hoping to be able to share results before the end of this year. So Lumakras or sotorasib, as I mentioned previously, is a small molecule or an oral medication that is very specific for the KRAS G12C mutation. The approval for Lumakras is specifically in lung cancer patients, and patients have to meet essentially 3 different thresholds to be eligible for Lumakras. First of all, it's approved for those patients where the disease has spread beyond the lung, or the patient is not eligible for surgical resection or surgical removal of their tumors. Secondly, as I mentioned, patients have to have the specific G12C mutation or the specific G12C protein. And the third is that the patients must have either failed, progressed, or not being able to tolerate it to a prior therapy. And that prior therapy could be chemotherapy, it could be a mix of immunotherapy, chemotherapy, and I'll share with you a little bit more detail in terms of the types of patients that we enrolled in our clinical studies. As we go through the presentation, I am also going to highlight some of the areas that you need to be aware of, and certain tests that your physician may want to do to help monitor for potential side effects that you may experience on Lumakras. Okay, so if we could go to the next slide. I want to spend a little bit of time talking about the study that led the FDA to grant Amgen an accelerated approval for Lumakras or sotorasib. This was a single-arm study that we conducted globally across 5 continents, and we enrolled 126 patients. As you can see in this very busy slide, if you could start on the left-hand side, these are all patients that had disease that progressed beyond their lungs or were not eligible for resection. Patients have progressed at least one prior regimen of therapy. They also have had confirmation of the G12C mutations, and patients had to have stable brain metastasis, meaning that their brain metastasis, if they had metastasis to the brain, had to be treated and stable before coming on to the study. We dosed our patients, or the patients received 960 milligrams once daily, and they were treated until either the disease progressed or they have to come off treatment because of an adverse reaction that prevented them from being able to continue treatment. The assessment of the outcome for this particular study was anchored around two parameters. The first one is we looked at objective response rate. What does this mean? Objective response rate is essentially a shrinkage of the tumor of at least 30%. Okay, so any patients that had shrinkage of the tumor for more than 30% on 2 consecutive occasions constituted a patient that achieved objective response on the clinical study. In addition to just meeting that threshold, we also implemented another stringent measure to remove any bias in the interpretation of these results. We did an independent radiology review. So we had this independent radiologist that review all the scans, and this ensured that we were very consistent in the way how we were measuring the objective response rate. Another major outcome of the study that we measured was how durable were these responses. So those patients that achieved an objective response rate, we follow the patients to see how durable the responses were. In addition to that, we also looked at what we call disease control rate. Disease control rate is not only those patients that had more than a 30% shrinkage in their tumors, but also had stable disease, meaning that the disease didn't shrink by 30%, but they also didn't progress. And then we are following the patients in the study to be able to understand the progression-free survival and what percentage of patients remain alive on the study as the study continues to follow the patient, okay? It's a lot of information, but I think it's important for the audience to understand how we measured efficacy in the context of our registrational study. So if we can go to the next slide, I'm going to share with you what were the baseline characteristics of the patients that got enrolled into the study. So you can see us starting on the left-hand side of the slide. We had a fairly balanced distribution between females and males out of the 126 patients. The median age of the patients that entered the study was 64 years of age. And you can see the racial breakdown on this particular slide. 99% of these patients had non-squamous, non-small cell lung cancer. So it's a subtype of lung cancer. And the majority of KRAS G12C is found in patients with non-squamous, non-small cell lung cancer. You can see also that 96% of the patients had stage 4 being defined disease that have progressed beyond the lungs, that had metastasized to other sites in the body. The most common sites where the disease had spread is highlighted on the right-hand side. In the top portion of the slide, you can see 48% of the patients had disease that had progressed or metastasized into the bone. We had about 20% of the patients that also had disease that had progressed to either the brain or the liver. In terms of prior therapy, you can see that 91% of the patients had received prior anti-PD-1 or anti-PD-L1, also known as immuno-oncology. 90% of the patients also had received prior chemotherapy before coming onto the study, and 80% of these patients had received both an immunotherapy as well as chemotherapy. And you can see on the bottom of the right-hand side of the slide, the breakdown in terms of how many lines of treatments the patient had been treated on before coming on to the treatment. So about 50% of the patients had received more than 2 prior lines of treatment before entering our clinical study. Okay, if we can go to the next slide, please. So what do we see in terms of efficacy for this particular study? One important thing to understand is that at the time that we submitted the data to the FDA, we had a median follow-up of at least 6 months in the patients, right? So it was an early snapshot in terms of the efficacy. As I mentioned, the study continues to follow patients, and we continue to assess scans in the patients. We continue to also monitor if the patients are still responding and what percentage of the patients are still alive in the therapy. The first snapshot when we submitted to the FDA is highlighted on this particular slide. So you can see 36% of the patients had achieved that objective response that I mentioned, meaning more than 30% shrinkage in their tumor. Out of these 36% of patients, 2 patients had complete disappearance of their tumors, meaning complete response, where on 2 consecutive scans, we couldn't find residual tumor. And then 35% or 43 of these patients had a partial response, meaning more than a 30% in the shrinkage of their tumors. 44% of the patients had stable disease, meaning that they didn't achieve that 30% reduction in their tumors, but their tumor also didn't progress. So it's basically what we call stabilization of the disease. So all in all, 81% of the patients derived benefit or had achieved disease controlled to sotorasib. The median duration of the response in these patients was 10 months, and 58 of the patients had duration that was longer than 6 months. And you can see the range here. We had some patients that had fairly short follow-up, where they had disease duration of about 1.5 months. And we also have patients that had more than 11 months of follow-up, right? So this median is just a snapshot in terms of what is that average duration of response for the patients that were enrolled in the clinical trial. If we can go to the next slide, what I wanted to now share is some additional data sets with a slightly longer follow-up. As I mentioned, when we submitted the package to the FDA with a single snapshot, we continue to follow the patients, right? So with longer follow-up, what we are seeing now is 37% of the patients have achieved an objective response rate. We had 2 additional patients now that have achieved a complete response. Our disease control rate is still 81%. However, the median duration of response has improved by about 1.5 months. We now have close to 2-year follow-up in our patients in the clinical studies. And later on in an upcoming Congress in the next month or so, we're going to be showing the 2-year survival for patients that were enrolled in this clinical study. Let me pause for a second here and see if there's any questions around the efficacy before we go into the safety.
And we do have a few questions via the chat. So what happened to the patients with a complete response?
Yeah, fantastic question. So we had 4 complete response out of the 126 patients that were enrolled in the clinical study. 3 out of the 4 complete response are patients that are still receiving therapy. All 4 patients are still alive today.
And why were patients only eligible for the trial if they didn't have brain mets?
Yeah, another fantastic question. So this is not uncommon for lung cancer trials to exclude patients with what we call untreated or unstable brain metastasis. The rationale behind this is twofold. We want to make sure that it's a homogeneous patient population that is enrolled in the clinical study. And the second factor is because when you're starting a phase 1 study, we really don't know if these small molecules can penetrate the brain and have an activity. So we want to make sure that we, pick the patients that are more likely to benefit from the therapy. That is not to say that we're not exploring the activity of sotorasib in patients with brain metastasis. We have an ongoing clinical study right now that will help us conclusively or more conclusively answer whether or not sotorasib may benefit patients with active or untreated brain metastasis.
How do I know if Lumakras is working?
Yeah. Great questions. Keep them coming. So in the clinical studies, and let me take a step back. Each individual patients may respond slightly different to Lumakras, and they may respond at different timelines during their treatment course. In our clinical studies, we did the first scan at 6 weeks, and then we repeated the scans every 6 weeks for the first 3 months, and then we extended the scanning. The median time to response in the clinical studies was about a month and a half. So what that means is that typically by the first scan, we already had a good sense of whether or not a patient is going to benefit and achieve tumor shrinkage from Lumakras.
This question is a testing question.
Yeah.
If you have to receive prior therapy before using Lumakras, why would I get tested at diagnosis?
I'm sorry, say that again. If you have to get
prior therapy anyway. Yep.
Yeah. So the ideal situation, once again, for testing is to test the patients at diagnosis before they receive any therapies, right? That is the best time to really understand the molecular profile, any specific type of mutations, and really develop a personalized treatment plan with your physician should you have a specific mutation. Now, the approval of Lumakras is approved in patients that have received a prior therapy. There are options here in terms of patients testing. You can look back if you had a comprehensive panel testing at diagnosis, and that can help you understand whether or not you're going to be subsequently, after failing your first-line therapy, eligible for Lumakras. In those patients that have failed prior therapy, that have not had a test done, then we need to repeat that test in order to understand whether or not the patient has a KRAS G12C. Because as I mentioned, Lumakras is very specific for that specific type of mutations. And the only way that we can understand whether or not you may be benefiting from or may be eligible to benefit from Lumakras is to do the molecular testing and see whether or not you have that specific mutation. Okay, hopefully I answered that question.
Okay, these are kind of two questions together.
Yeah.
So if you could go through the scan timelines from the trial again.
Yeah.
And also, are scans the only way to know if Lumakras is working?
Yeah. Great questions. So the way how we, in the clinical trials, the scan was done at baseline. We want to understand what is the baseline tumor size that the patients had. And then when the patients start treatment, the first scan to assess for efficacy is at week 6. And then we repeat it every 6 weeks. As I mentioned, we applied very stringent criteria for the assessment of objective response rate. And this was done in a sense of making sure that we met the regulatory requirements for the submission to the FDAs. So we did what we call a confirmed objective response rate. What that means is that we had to have 2 consecutive scans that confirmed the same findings. So for example, for the patient that had a complete response, that had to be confirmed on 2 scans 6 weeks apart. The second thing that we did is to have an independent radiologist that review all the scan. That way we are reading all the scan in an unbiased way, right? We're not having different radiologists from different hospitals reading scans and interpreting the results differently. The second part of the question, I think, was related to, is a scan the only way to understand whether or not you're going to be benefiting from Lumakras? There's 2 ways to break down the benefit from Lumakras. the best way to understand whether or not your tumor is shrinking and responding to LUMACRAS is the scan. However, there is also symptomatic relief of patients, right? So where once a patient starts treatment, this is not just specific for LUMACRAS, but any therapy where the patient starts to get better, right? They have less symptoms in terms of less shortness of breath, and some of the pains that they may be experiencing may start to go away. So there's two ways of assessing the efficacy. There is the radiology assessment of efficacy, and then there's the symptomatic assessment of the efficacy.
Do you have to be PDL positive to receive LUMACRAS?
Yeah, another great question. So PDL1 is a specific marker that typically will help assess whether or not a patient may benefit from immunotherapy. The interesting part is that KRAS patients oftentimes will also have PDL1 expression. The short answer is no. You don't have to be PDL1 positive or negative to benefit from LUMACRAS. In our clinical studies, we were able to collect samples from a handful of patients that had PDL1 status already understood, and we saw activity for LUMACRAS independently of the PDL1 expression of the patient. So whether you're PDL1 positive or negative, we did see responses in the clinical trial.
Are these results all monotherapy results, or does this also include combination data?
Yeah, another great question. So this particular result that led to the FDA approval is monotherapy LUMACRAS. We are also conducting a number of studies to look at the combination of LUMACRAS with immunotherapy. We're looking at combination of LUMACRAS with chemotherapy, combinations with antibody-based therapy, and other small molecules. Those clinical trials are still ongoing right now, but the approval of LUMACRAS is as a monotherapy.
Okay, and last question before we continue on. Are there plans to get LUMACRAS approved in the first line?
Yeah, another excellent question. Yes, efforts are ongoing to understand not only the population in first line that benefits the most from LUMACRAS. So we are looking at both LUMACRAS as monotherapy and seeing what segment of patients in first line could derive the most benefit, but also many of the combination approaches that we're looking at with LUMACRAS is looking to see whether or not we can enhance the benefit, and is there an opportunity to potentially bring LUMACRAS in a clinical trial into the first line setting.
And I have a couple quick questions if I could before we kind of move on, if that's okay.
Absolutely.
Right. Okay, so are the doctors getting the same information that we are right now?
Yeah, we hope so. We hope so. Yes, we do have various efforts, Terry, to ensure that physicians are getting the same information. And as more information starts to come out for LUMACRAS, that we are updating physicians to ensure that they have the right information to guide their decisions for patients and to guide the treatments for patients. We have various channels for this education. We have field-based staff that work with ensuring that physicians get the right educational materials. We also work with many organizations such as advocacy groups, professional societies, community networks to ensure that the information reaches the physicians.
For sure. And as patients, I can tell you, I know that the only way I know for sure if my doctors have the conversation is if I bring it up with them. So that's just me speaking out. And then the other question I had was, what data is there on the symptomatic relief endpoints?
Yeah, so we did present recently, and you know, the best way to do and understand what we call the patient-reported outcomes is to do it in a randomized fashion, right? So as I mentioned, we have a confirmatory study that has completed enrollment, and we're just waiting for enough follow-up before the study reads out. That particular study is a study comparing Lumakras to docetaxel, which is the standard of care right now in this patient population, which is previously treated lung cancers. That particular study has extensive patient-reported outcomes, and that will give us a better signal in terms of the improvement in symptoms and improvement in outcomes for patients above and beyond the clinical endpoints.
And I had another question hit me up with, is it reasonable to expect to see the data before the end of the summer?
I'm sorry, say that again.
I'm sorry. Yeah, I'm sorry. I tripped over my tongue. Is it reasonable to expect to see the data before the end of the summer on the PrEP?
Data for the
For the existing trial, I'm assuming what is.
Yeah. So very good question. The study continues to follow patients, right? So we continue to follow patients for progression-free survival, for survival outcome. As I mentioned, we will be presented updated survival data at a Congress in April, where we will be characterizing what we call the long-term outcomes or long-term survival for the patients. So absolutely more to come.
Yeah, that's probably the AACR conference of the end.
Yes, it is.
So yeah, and so we're excited. We are very excited to be hearing that. Let's see, there was something else too. Hang on. Let's see. Somebody asked about colorectal cancer. How does Amgen have any idea how close they are for getting FDA approval for Lumakras and colorectal cancer? Is the question.
Yeah, a very good question. So the data for monotherapy colorectal cancer has been published. It was published late last year in Lancet Oncology. It is currently not FDA approved in colorectal cancer, but there are multiple efforts that are ongoing right now and multiple clinical trial options that we're looking at combinations in colorectal cancer. We believe that the best way to target KRAS G12C in colorectal cancer is probably not the monotherapy approach, but a combination approach. So there are combinations with monoclonal antibodies that are, these trials are opened and available for patients. There is also combinations with monoclonal antibodies plus chemotherapy and sotorasib that are enrolling patients right now. We are hoping that these studies will evolve over time and that we'll be able to bring the therapy to patients and get FDA approvals down the road.
Like we're derailing your presentation. Why don't you just keep going?
Sounds good. So let me maybe switch gears a little bit and talk about the safety profile of this particular drug. If we can go to the next slide. Oops, I'm sorry. Before we do that, so let me close up by also sharing with you what we have seen so far in terms of the median overall survival and the progression-free survival. So once again, early snapshots in the follow-up for the patients, but the median overall survival is a little bit over years. It's 12.5 months at the time that we submitted the data to the FDA. And the median progression-free survival in these previously treated patients is about 6.8 months. Because of the efficacy profile that I share with you, the FDA granted us the accelerated approval. And in parallel to that, the NCCN also incorporated sotorasib or Lumakras as a recommended regimen for patients with KRAS G12C that had received prior treatment. Okay, so now if we go to the next slide, wanted to make sure that the audience is also aware on some of the safety informations. So two aspects in particular to highlight on this particular slide is because Lumakras is metabolized or cleared by the liver, one of the side effects that patients may experience is what we call hepatotoxicity. More specifically, these are elevations in the liver enzymes. So many cases, patients are not symptomatic, and the only way to detect this is by physicians getting a blood test and noticing that the liver enzymes are elevated. So because of this, it is important that physicians monitor what we call liver function tests, or LFTs by short, on a routine basis and make sure that you're not experiencing one of these adverse events or hepatotoxicities. It's also important to make sure that you inform your physicians if you have a history of liver abnormalities, if you're experiencing any conditions that may signal damage to the liver, such as yellowing of your eyes, if your urine turns a dark yellow or brownish color, or you have itching in the skin is another sign of liver damage. The second adverse events to keep in mind is LUMACRAS can cause an inflammation of the lung. It's a very similar inflammatory response as you can see with other therapies such as immune checkpoint inhibitors. So it is critical for a patient that's being treated on LUMACRAS to inform the physicians right away if they're experiencing any shortness of breath, any new cough symptoms, or any fevers, as these could be a sign of this inflammatory flare, inflammatory reaction that you may be experiencing. There are options to manage these toxicities, but it's critical for the physician to be aware of these early on, right? And management can entail interrupting the dose. It could entail also reducing the dose to be able to mitigate for these toxicities or adverse reactions. It may require permanent discontinuation in some cases. And in some cases, there may be additional medications that your physicians may offer you to help with the management of these adverse reactions or side effects. Okay, if we can go to the next slide. Just very quickly, the most common adverse reactions or side effects that we saw in our clinical trials are listed here, included GI symptoms such as diarrhea, nausea. We did have patients that report muscle ache or muscle pain. Tiredness or fatigue is another side effects that we saw. I mentioned the liver problems or liver toxicities, as well as inflammations into the lung can also be seen as side effects related to LUMACRAS. And in some cases, we also saw abnormalities in blood tests beyond the liver, such as changes in white blood cell counts or changes in red blood cell counts. Okay, we could go to the next slide. Want to conclude the presentation by giving you some information on how to take this medication and also what additional resources may be available for a patient that may be eligible for LUMACRAS. So if you could please advance the slide one more time. Okay, very, very busy slide, but in a nutshell, LUMACRAS is an oral medication. The current FDA-approved dose is 960 milligrams. It comes in 120 milligram tablets. So this means 8 tablets once a day. It can be taken on an empty stomach or it can be taken with food. It should be swallowed whole. It's not a squirt tablet, so it should not be broken before taking the medication. We do realize that in some cases, patients may have difficulty swallowing the tablets. So as you had mentioned, Terri, previously, there are alternative mechanisms. For example, the LUMACRAS can be dissolved in water before it is administered. It is important to note that if a dose has been missed, if you miss the dose within a 4-hour window, you should repeat the dose. But if it's been more than 4 hours since you missed the dose, the recommendation is that you skip that dose and you get back to your routine the following days. In the event that a patient throws up after taking the medication, the recommendation is not to repeat your dose as the drug is absorbed fairly quickly, is that you just basically skip and wait till the next day and you restart your regimen again. There are certain drug interactions that is important to note because, as I mentioned, LUMACRAS is clear through the liver. So before you start any medications, whether it's a prescription medication or if it's an over-the-counter medication, make sure that you inform your physician of these new medications, because it's important to check and make sure that there's no drug interactions with Lumakras. The other important drug interactions or potential drug interaction to note is the absorption of Lumakras can be impacted based on the acidity of your stomach, right? So this is part of the reason why we encourage to avoid antacids medications if possible while the patient is taking a Lumakras. But we also realize that this may not be possible. So the current recommendation is to switch the patients to what we call the short-acting antacid if possible, and to also space out the administration of Lumakras with the antacid. So the recommendation is to take it 4 hours before the antacid or 10 hours after antacid. This way you minimize any potential drug interactions and you minimize any potential absorption impact to Lumakras. Okay. Any questions that may be coming in around this before I wrap up and share with you some resources?
I have a couple quick questions, yeah, if we could. Are there any, because we're on this, are there any foods that you should avoid?
Yeah, very good question. So the metabolism of Lumakras is through the liver and through the cytochrome P350 system. It's the most common enzymes in the liver that clears this. And there are certain drugs that can actually change the level of the cytochrome P350. For example, grapefruit juice is something that you want to avoid. Some of the types of, for example, blood oranges is also something that you want to avoid. But your physicians will be able to provide you with also a list of medications as well as food that you should be avoiding. Herbal medicine is also something that should be avoided, as in many cases, herbal medicine can also change the clearance of Lumakras and can impact the liver metabolism of the drug.
So any sort of a supplement, not necessarily just a medication, you should make sure that you tell your doctor about, and then make sure that you understand what you can or can't eat, like grapefruits or blood oranges or something, right?
Yeah, absolutely.
Okay, let me look back and see if there's anything else here too. Oh, you were talking about the liver function. What type of monitoring do we do in a patient to monitor those things?
Yeah. So the liver function test is what we routinely would do, and includes a number of parameters. So the most common sets, you'll hear physicians call a liver panel, and this constitutes measuring AST, ALT, ALK phos. In many cases, physicians will also want to check your bilirubin levels to see if there's any damages to the bile duct. And in some cases, you also hear physicians get a GGT, which is another measure to see whether or not there is any potential impact to the bile duct. The measuring of these liver enzymes, typically physicians will want to check your liver enzymes at the time before starting Lumakras, just to get a baseline. And then the recommendation is to do this every 3 weeks for a period of time. And then you can extend the frequency of the liver function test once the patient has been on Lumakras for a period of time.
And what about like other things like white blood counts or CEA, any of those other things?
Yeah, so blood tests beyond the liver can include getting a comprehensive panel, for example, checking electrolytes, checking for bilirubin, serum creatinine, and also checking for your blood counts, right? So the physicians will check for your white blood cells, your platelet counts, and your hemoglobin levels to make sure that there's no impact from Lumakras or it's not a side effect the patient may be experiencing.
We got a chatty group. I hope you're ready for us. We got a couple other things that are like popping in here. I know we're going to hit that. See, okay, somebody mentioned something about dairy. Is there any indications one way or the other on dairy?
On dairy products, not specifically. So Lumakras can be taken with or without food. The only thing to really avoid at this point is any potential interactions in terms of the spacing of the drug for any antacids that may change substantially the acidity of the stomach. But it can be taken with or without food.
I'm just going to read the question. Is there info regarding the efficacy on Lumakras at a lower dose?
Yeah. The way how we conduct phase 1 studies is what we call a dose escalation, right? So we start at very, very low dose, 120 milligrams, and we start to work our way up. What we saw in the clinical studies is across each of the dosing cohorts, as low as 120, 240, and we started to escalate, we saw patients benefiting at each of these levels. There is a dose comparison study that is ongoing. At this point, we don't have the results available. The FDA approved dose and where we have the most robust body of evidence is 960 milligrams.
Okay, so we'll stay tuned for that information. And then has Lumakras been tested in an IV form instead of a pill?
Yeah, we don't. We have not. The development of this particular product has always been a oral formulation. So we don't have an IV formulation. We didn't test it as any other formulation.
Okay, and as I'm just hitting the questions as we go.
They're great. They're great.
Does the risk of side effects go down the longer ones on the Lumakras?
Yeah, it's a very good question. We will be presenting also some of this data with a longer follow-up. But as you start to go out on the period of time in your treatment, the side effects do start to trend downwards. The other thing to keep in mind also is there are ways to manage these side effects, right? The key here is sharing with your physicians if you're experiencing a side effects, and there are ways to mitigate. For example, there are medications that the physicians can give to help overcome some of the side effects. There are also dose interruptions that we can implement to help, the side effects alleviate before we starting the medications. And there is an option also to go down on the dose for those patients that may be experiencing side effects. But the key here is, I can't emphasize enough, it's share the side effects with your physicians early enough so that you can explore options.
There's a few questions about the dairy, taking dairy with Lumakras, and it seems like there's a lot of questions about whether a cup of coffee with cream is okay.
Yeah, absolutely. So we did study in our clinical studies. We had a cohort of patients that received food and a cohort of patients that received Lumakras on the empty stomach. The bottom line is that food such as coffee, creams, milk does not really impact the absorption of Lumakras.
Another one just hit. Have you done any studies on those who have had a partial or complete response and lowering their dose so that may possibly extend the time before the liver has issues or the drug no longer works?
Yeah. So I think the question is related. Patients that start on 960 experience an efficacy and whether or not you can lower the dosing at that point, right? Particularly if they're experiencing the side effect. So we haven't done a study that prospectively looks at an intentional reduction in the dose of Lumakras in those patients that have benefited. What we have seen in the clinical studies is those patients that had an adverse reaction or side effect going down to a lower dose and continuing the therapy and not losing their response. Okay, so just in the event that you have a side effect or reason to lower the dose, we have seen patients that have maintained the response and not lost their response at a lower dose.
Cool. Okay, does Lumakras help reduce the tumor at the primary lung site and also other metastasized sites?
Yes. So when you conduct a study, we usually have what we call target lesions, right? Those are the lesions that we measured for the efficacy of the clinical studies. But we have seen responses for patients in various sites above and beyond the lung.
Well, we're going to let it go for right now. Let's just keep rolling with your slides. Thanks
Okay.
so much for being so open to the questions.
Now, these are incredibly, very, very good questions coming in. So I just have 2 more slides to conclude the presentation. I just want to wrap up by providing some resources that we have developed here at Amgen. So we have a set of resources for patients, and we also have sets of resources for physicians. So on this particular slide, there are 3 different resources that are available for patients. We have our Amgen Nurse Navigators. These are single point of contacts that can provide information not only on LUMAKRAS, but all products that are provided through Amgen. We also have referrals for patients that may be wanting to look for counseling or local support groups. And we also have a 3rd set of resources, which is really to help patients with financial and copay assistance. If there is any interest or you want to get additional information, there is a 1-888 number on the bottom of the slide where you can get more information, or you can also go on the website at amgenassist360.com. Very great resources that will help you navigate through questions that you may have, or can also support you with any types of local support groups or financial support that you may need should you be eligible for LUMAKRAS. Okay. If we can go to the next slide, and this is my very last slide, these are some additional resources that are available for healthcare providers or your physicians, right? We have Amgen reimbursement counselors. We also have a group of teams, both housed here in remotely as well as available in the field, that can also help with verifying benefits, right? Insurance benefits for patients, and also help with any sort of challenges that you may have from the reimbursement standpoint. Same number as the Amgen 360 on the bottom of this particular slide. But the bottom line here is we have ample of resources both for patients as well as healthcare providers, and we are always available as an organization to help you navigate through any questions that you may have surrounding the use of LUMAKRAS. Okay. So with that, that is my very last slide. Any additional questions or feedback that may be coming in?
Let's see. Let me see what I've got here. How is LUMAKRAS defined? Is it a chemo drug? Some define it as infused, etc. I can't figure out exactly what would it be called?
Yeah. It is called a small molecule. Yes, the best way to define this is a targeted small molecule.
Yeah.
Wait a minute. For insurance purposes, you know how they define, we cover chemo drugs, or we cover, and then they define them as something like, or we cover immunotherapy drugs. Is there a consistent definition of what it is to make it easy, not to make it easier?
Classification of drug.
Like, is anybody understanding what I'm asking? I'm in the middle of doing it. That's why.
Okay, hang on there, Trish. Okay, give us a chance to answer. Okay, I think what you're saying, what the question is, because it's not an immunotherapy and it's not a chemo. What is this? And it's a small molecule drug. Correct me if I'm wrong, please.
Yeah.
It's a small molecule drug and it's considered a targeted therapy. Is that correct?
Yeah, Terry, I think what the question is the coding for the insurance companies, right? Yeah, and so I think most insurance companies will call this an oral oncolytic agent. That's the code that they usually put it under. More specifically, it is a small molecule or a targeted therapy.
And Trish, we will reach out to you. Someone from Amgen will reach out to you.
All right. Do you guys have any questions? I'm looking through here to see if I missed anything. Hang on. Okay. All right. I'm going to throw one at you just because I've got one. Okay. So I know that they call it a LUMAKRAS. In,
Uh-huh.
in the UK, it's due to Lumakras. Okay. Is that just to confuse us?
Yeah, it's probably beyond me to answer that, but it's typically, when we have names, we submit it to the regulatory authorities, and there's a body that looks for, acceptability for various names that comes up, right? And so it's a variation between the EMEA and the FDA in terms of, what was an acceptable trade name for Lumakras.
Okay. And then, and just so I can make sure I've got, all right, I know that okay, so if I buy Kleenex is a tissue, your brand name is Lumakras, but the drug name is sotorasib. Is that correct?
Yeah. So there's a different category. So if we want to go all the way back, right? So when we develop a drug, the first set of names is a compound number. So you will also hear AMG 510 being referred to Lumakras. Once a drug reaches a certain milestone in the development, it gets assigned a generic name. And the generic name is sotorasib. And then once it reaches a certain threshold, as we get closer to the FDA approval, the FDA will then grant a trade name. The trade name is then Lumakras, and that is assigned to the asset once the FDA approval or the regulatory approval comes through.
Okay. All right. I see. I got another question in here. I was told that the Keytruda, the immunotherapy, didn't work because of the G12C mutation.
Yeah. Yeah, it's a very good question. Of course, we can't really comment on a specific case. But if you refer back to my earlier slides, about 90% of the patients that were enrolled in our registrational clinical studies had failed PD-1s or PD-L1s, immunotherapy. And Keytruda falls into that category, PD-1, PD-L1. So in a nutshell, we had a fairly large number of patients that went on to receive Lumakras and benefited from Lumakras. What I don't know and I cannot comment on is the other way around, right? Is if a particular patient's failure to benefit to Keytruda was associated to that specific mutation.
Because we have to look in general cohorts, which are groups, and the groups, and compare the groups in how it looks in general. Let's see. For those with complete response that are still on a drug, are they still on a full dose? Or the one that they no longer have?
So out of the 4 patients, 3 out of the 4 is still receiving the full dose and still deriving benefit. All 4 patients are alive. 1 patient did discontinue therapy because of side effects, but still alive.
Okay, great. I don't see any other questions. You have been just an absolute delight. Thank you for having. She said, okay, so she said, did they have a recurrence after they stopped taking the medication, or are they still being watched after they came off?
Yeah. The patient is still being watched.
Okay. All right. Thank you so much for being here today and being so approachable with the questions and the interruptions and dealing with our little Zoom hiccups here at the beginning of the event. We really appreciate everything that you're bringing to it and how fantastic and approachable it is. And so we are recording all this, and so that we can go back and go through it and watch it as that all gets taken care of. So thank you so much for being here with us today. I have one other question. I think Michelle might be the right person to ask. If I'm a patient and I wanted to share my journey, how do you guys do that? How does that work?
Yeah, thank you, Terri. First of all, phenomenal conversation, engagement. We're having a hard time keeping up with the chat. So again, thank you, Terri, and thank you all for your engagement this morning. It's truly a privilege to us, on behalf of the team here that's with me. So Terri, you asked a great question because we've been very fortunate to meet some of you. I recognize some of the names. And so if you do want to share your story, your experience with us, if you're on sotorasib, we've given Terri a form that gives us the permission to contact you. So if you would like, a little bit of background noise, but hopefully the process is pretty simple. And again, we feel privileged whenever we get to hear your stories. It helps us, improve our systems and processes and the information and resources we get out. So again, Terri has a simple form which just gives the permission for us to contact you. And again, thank you very much for the incredible engagement this morning. Phenomenal questions.
Well, thank you guys so much for doing all of this. I really appreciate it. And okay, so just let me clarify with you, Michelle, too, because if I sign that form, I can retract it and say, that's it, I'm done talking to you. I don't want to talk to you anymore. I'm not signing away my firstborn or the dog or the house or anything, right?
Yeah, no, absolutely. So I'll give you a great example. We were lucky to be here today, and we have some of our colleagues on the line, but oftentimes you'd be amazed at how many teams, even in the clinical development side, never get to meet the patients and hear from the patients that after years of hard work are receiving a treatment they worked on, they helped to discover. And so oftentimes we invite patients to come to an all-staff meeting. We also have opportunities where it's a smaller workshop. Share with us your experience. What was challenging right now as you went to navigate your diagnosis and your, I don't like the word journey, it's really the experience you're having, and it looks very different today than it did pre-pandemic. And so there are different ways we appreciate the opportunity to engage with you. So hopefully, Terri, that answers your question about how we engage with patients.
Yeah, no, I think so. Okay. No, thank you guys so much for all being here. And does anybody have any like last minute questions or anything that they're just like burning on their hearts here that they need to get a shout out? Okay, I see Gwen is raising her hand. Okay, Gwen. Oh, you're muted. Hang on a second. Let me unmute you. Can you unmute yourself?
I'd like to know on your phase 2 or 3 trials, how did the patients do with the Lumakras and the Keytruda combined?
Yeah. First of all, thank you for sharing your experience. In the clinical studies that we did, the data that I share with you, we did not combine Lumakras with Keytruda. They were done separately, right? So most of the patients had Keytruda first, came on to Lumakras, or vice versa, had Lumakras and then subsequently, after they progressed, went on to receive Keytruda. We do have ongoing studies right now to look at the combination of Lumakras and Keytruda. Those studies are enrolling patients as we speak, and hopefully later on in the year, we'll be able to share that information publicly. But those studies are ongoing as we speak.
Okay, I think I would be a great candidate, but thank you for the information.
You're very welcome.
Guys, all right. Well, hey, look at us. We're actually running on time. This like never happens. And thank you all for being here today. And thank you, Amgen, for coming in and being willing to share this sort of information with us in an approachable way. We had to jump through some hoops to do it. And you guys have just been great speakers. And of course, we have a fantastic audience. And so that's part of it. Everybody's always afraid that we're going to get crickets in our rooms. It's like, no, we are an educated and empowered group of folks, and we're not afraid to ask questions. And so take this information back to your doctor, share the information. If you have questions about you need to talk to them. But thank you guys so much for being here today. And we applaud everything you're doing, and keep on kicking cancer's KRAS. It's like, that's what you got going on.
Thank you, Terri. Thank you so much for the invitation, and thank you for allowing us to spend the last hour and a half with all of you.
I hope we didn't wear you out too much. It's just the beginning of your day.
It was great. The questions were incredible. Thank you.
Thank you so much.
Okay, thank you guys. Thank you all. Thank you all for seeing you. Okay, and we'll see you guys next week. You stay in touch with the events and stuff we got coming up, and we'll talk to you soon. Take care, y'all. Bye.
Bye.